Hi, good afternoon, everyone. Thank you so much for joining Jeff Foundation's Community Workshop Series. We're going to just wait here a few more seconds to just allow some attendees to get on, and we'll begin in about 2 minutes. Thank you. Right. Hi, everyone. Again, good afternoon, and thank you for joining Jeff Foundation's Community Webinar Series. For those of you who are listening, my name is Danielle Edwards. I'm the Director of Community Engagement at Jeff Foundation, and I've been a part of the organization for almost 5 years now. While I wish I could be doing this in person at our traditional family workshops and meeting you all face to face, I'm so glad to be able to provide you with the virtual educational series. This year, our virtual webinar series is to help ensure our Duchenne community be better prepared on certain topics and provide a sense of education and relief. Today, I'm so excited to have Dr. Cifaloni, who is a neurologist at the University of Rochester, with us today, who will be speaking on corticosteroids and Duchenne, what's new? That is presented by our friends PTC Therapeutics. Please make sure to drop any questions you may have for the company in the chat section below, so Dr. Cifaloni can answer any questions you may have after the presentation. With that being said, thank you all again for joining. I hope you enjoyed the webinar today, and I'll pass it over to you, Dr. Cifaloni, to begin.
Hi, I'm Emma Cifaloni. I'm a professor of neurology at the University of Rochester in Rochester, New York, where I direct our Duchenne clinic, among other things. And I'm very excited and glad to be here to present to you a summary about corticosteroids in the management of Duchenne. And I would like to put it in the frame of what's old and what's new. And to begin with, here is my disclosures. So here are my full disclosures for this presentation. I think the more pertinent really for this discussion is that I am being paid by PTC to actually prepare this lecture, the content, and this presentation. And also, you know, it's important that I am a site investigator for many clinical trials in Duchenne muscular dystrophy. So what I would like to cover in our conversation today is really to review the role of corticosteroids in the care of Duchenne muscular dystrophy patients, but viewing specifically what is really new and how much have we learned in the past few years, and how has the community and the field really improve the standard of care when it comes to corticosteroid in Duchenne, because there has been quite a remarkable improvement that we all should be really be proud of, and overall a positive trend about this topic. Also to review the decision making for corticosteroids and some of the key questions like when to start, which corticosteroids, what kind of regimen, and for how long. And then to review some newer evidence on both prednisone and the Deflazacort in Duchenne. So just to put it in perspective, it's always very interesting to see how in our rare diseases, and obviously Duchenne is a rare or probably ultra rare disease, what kind of progress, what is the timeline? Because I know that sometimes it might feel a little slow, obviously. On the other hand, I think that the past several years have really seen a very significant acceleration of progress in Duchenne, which is very, very exciting. And I think it's only continue, it's going to continue to accelerate in the next few years. So just to put in perspective, corticosteroids therapy for Duchenne has been around since the 70s, but you know, the very first observation was done in the 70s, but really the first published, and we're going to go over this trial in Duchenne and corticosteroids was in 1989. And then in the 80s and 90s, we have learned so much about, even without any disease-modifying drugs, that the natural history of Duchenne could really be altered in a very positive way, and in improving survival and morbidity with more aggressive care, especially pulmonary care and spinal surgery. So those were really big learning points. And then later on, we learned that really being preemptively aggressive in the cardiac care and starting cardioprotective medication early on in the course of the disease also has a favorable outcome. And then more recently, since 2016, we now have 5 FDA-approved therapy for Duchenne that are listed here in the right lower corner of the slides, you know, and some obviously are the exon skipping medication, which are really new disease-modifying medication, and then the Deflazacort that got FDA approved in 2017. So things are accelerating and definitely going in a very nice direction for Duchenne. So in the interest of the historical perspective, but it's very important because when your doctor is going to have the conversation with you and your family about steroids, that's where it really comes from. And sometimes the visual can be very helpful. So this is the original clinical trial done in 1989. And by the way, this was published in the New England Journal of Medicine, which is really one of the most prestigious journal in the literature. And what you see here is basically that prednisone was studied in 103 boys with Duchenne between the age of 5 and 15. And the researcher really looked at the muscle strength. Okay, so over here, you're going to see over time. And these lines, you know, this dark line down here, this is the natural history. This is what happened to the muscle strength, meaning going down, so negative deflection, that means decreasing in muscle strength with the natural history. So Duchenne muscular dystrophy with no prednisone at all. This is how much it decreases over 6 months. In the dotted line here is the placebo. So that's when they gave a placebo to some of the patients. And these 2 lines shows you what happened in terms of muscle strength when prednisone was given at 2 different doses. 0.75 milligram per kilogram, which is really the classic dose that we now is well established for prednisone, or 1.5 milligram per kilogram each day. So they started 2 different doses. And you can see here basically that what they demonstrated that by even as early as 1 month after starting prednisone, the strength goes up in the prednisone. It peaks and get maximal improvement at about 3 months. And then it kind of plateau, and this is at 6 months. And what happened to the people that are not treated with corticosteroids is that they slowly, but surely and progressively go down in terms of strength. They also study other measures like time to rise from supine, walking 9 meters, climbing 4 stairs, and the pulmonary function test. And really, all of those were also significantly improved in those patients that were treated with prednisone versus the ones that were on placebo. And side effects were also discovered, and the top 3 side effects in that trial were weight gain, cushingoid appearance, and excessive hair growth. And we're going to talk more about that. So that was kind of an historical trial. But what do we know now? So when that was a trial really for 6 months, but why corticosteroids? So now we have a very large amount of additional literature data that really tell us that corticosteroids are definitely beneficial in the treatment of Duchenne. And the way to think about this, though, is short-term effect of the therapy, like, you know, frequently trial, they just look at 6 months. And then really, you know, we know the corticosteroids, once you start, you're on it for decades. So what is the long-term corticosteroids advantages? And so it's really important to think about it like short-term and long-term. So short-term, we have plenty of data and literature that tell us that definitely the muscle strength and the muscle function is beneficially impacted. There is improvement also in urinary excretion of creatine, which is really a sign of muscle mass, so a good thing. And then also, very importantly, even on the short term, an improvement in your lung capacity and lung function, which obviously is very, very important. For long term, we now know from several different cohorts and study that corticosteroid treatment really have the ability to prolong the ability to ambulate by 2 to 5 years, so very significantly. Also, it reduces need for spinal surgery. There is also an impact on delaying the onset of cardiomyopathy, cardiac problems, and also delaying the need for non-invasive ventilatory support. And overall, a significant improvement in overall survival. So these are the things that we're gonna dig a little bit more into details. So it's very important also to remember that corticosteroids have now pretty much have been agreed upon our community of experts in the field, patient organization, such as the Jet Foundation, and all different parties that have you know, an interest in Duchenne. And this is well documented in the updated published guidelines, standard of care for Duchenne. And as you know, they were published initially in 2015 and then updated in 2018. So I just wanted to emphasize this and show you that in these care considerations that have been published, and these, I quote this, it states in terms of treatment, the care considerations say physiotherapy as described in the section on the rehabilitation management and treatment with glucocorticoids remain the mainstays of Duchenne muscular dystrophy treatment and should continue after loss of ambulation. So this is a strong treatment because it tells you that it's pretty much established universally as standard of care, mainstays, so it should be offered and discussed at the time of diagnosis. And also, and this is the new part in the updated version, the 2018 care consideration, that should continue after loss of ambulation. And this has really been this is something new, I will say, because if you think about 10 or even 20 years ago, although corticosteroids were used, usually the trend was that once the patient is no longer able to ambulate and rely on a wheelchair use, most physicians will recommend stopping the steroids. Over the years, where we have actually learned so much new information that continuing corticosteroids after loss of ambulation has so many favorable impacts on many other important milestones, such, preventing scoliosis, preventing cardiomyopathy, preventing respiratory failure, and also maintaining upper extremities function, which is obviously huge for community functioning and quality of life. So there has been a significant improvement in our knowledge and also in the agreement in the community. So really, the guidelines, the care consideration that have been revised in 2018 have really gone by about 8 different topics to 11. And the new topics include management in the emergency room and by primary care physician. There is a new section on management of endocrine, like bone health and growth and delayed puberty, and also transition of care to adulthood. I'm talking about all this because obviously you cannot disconnect, treatment with corticosteroids and standard of care and management of the side effects that come with the use of corticosteroids. So this is just a reminder that as we review treatment with corticosteroids, and also more importantly, as new disease-modifying treatments are being approved by the FDA, it's very, very crucial to remember that you still have to maintain a multidisciplinary approach to the care of Duchenne in order to accomplish the best outcome. So it will not make much medical sense to initiate some of these medications, especially corticosteroids or any of the other medication, without first having well-established multidisciplinary care, which obviously include many different specialties. I suspect that many of you are actually very familiar with this model. Probably many of you belong to clinics that are able to offer a genetic diagnosis, genetic counseling, but then, really co-managing with pulmonary and cardiac specialists, orthopedic specialists, physical and occupational therapists, and GI, and so forth. So it really takes a village to best take care of Duchenne, and you really have to have this, because this is it becomes important when we review some of the data and the data about corticosteroids in the setting that unfortunately standard of care is not universally implemented in all patients. And so those differences can actually influence some of the results that we're going to discuss. So in short, what the care guidelines state, and everyone in the field have agreed, that the benefits of corticosteroids are multiple and are listed here. So improving survival, preservation of muscle function and strength over time, delay the loss of ambulation, preserve cardiac and pulmonary function, and also slow development of scoliosis. And this is really, in summary, what the CDC and many in the fields and experts have agreed upon, that there is plenty of evidence to really support these important statements. And I'm bringing this up because sometimes it's very hard, especially if you're at the beginning of the journey with Duchenne, you know, perhaps you would expect that you're going to start a medication, you're going to see improvement in muscle strength, like running and walking, but it's bigger than that because we are really looking at the long-term effect on many other organs, including the lungs and the heart and the scoliosis. And those necessarily you might not perceive, obviously, because they're long-term, but it's important to put it in that perspective. And this is just a panel to remind you that if you actually look up at the care guidelines, this is really what is recommended in terms of the discussion in regard to corticosteroids. And it's really, this should be an initial discussion after the diagnosis is confirmed and discussed with the family. Really, the recommendation is to start steroids before substantial physical decline. We're going to talk about that a little bit more because this has been left a little bit vague. And I think that the age when we recommend starting steroids have been moving to a little bit younger over the past several years. And we're going to review that a little bit more. And also with the recent effort in the community to push for newborn screening for Duchenne, that age of when corticosteroids should be started also is going to become more and more relevant. Obviously, the discussion needs to be very much focused also on the management of the many and well-known side effects. Also, you should have a meeting with the dietitian prior to initiating corticosteroids, and then a discussion about different dosing. You know, daily prednisone versus daily deflazacort is what is most usually recommended, and here is the doses are listed and so forth. And this, you know, the care guidelines are obviously very easily available on many websites in a version that is also a little more friendly for patients and but also version for providers. So and basically, this is really what is recommended, that is now recognized as a mainstay, cardinal feature of management of Duchenne. It should be offered to all patients with this diagnosis, that usually most people will consider initiating corticosteroids between 2 and 5 years of age. Usually it's more 4 or 5, sometimes 3. I think that 2 is a little bit unusual. And the big important change in recent years is that now the recommendation is to continue corticosteroids after loss of ambulation, but obviously to continue to monitor very carefully for side effects and to adjust the dose accordingly. The other thing that is new and very important in the care consideration is also the reminder that patient and family needs to be educated about the fact that corticosteroids, this is a chronic type of treatment that we deal with in Duchenne, and therefore it can potentially be very dangerous to stop this medication suddenly, or for example, if patients run out of prescription, or if the child is sick and throwing up and not able to keep their pills down. So now it's all very precisely described in the endocrine guidance there, how to manage the potential risk. So hopefully I gave you kind of a quick overview of what we know very well, okay? Unequivocally, corticosteroids make a huge positive difference in the natural history of the disease, and they slow down the progression of many different aspects of Duchenne dystrophy. But there are other points about corticosteroids where uncertainty remains. And if you do see perhaps different second opinions or different providers, or depending where you are in the world, there is still some uncertainty or equipoise. And so among the most important issues is that unfortunately all this incredible body of evidence to tell us how effective corticosteroids are has unfortunately not translated very uniformly in true clinical practice. So, and I'll show you some data about that. There is a very, very significant inconsistency in the use of corticosteroids, which remain a major problem in the community, and even more of a problem now that we have so many clinical trials ongoing. The fact that patient might be on very different type of regimen of corticosteroids is going to make the design of those clinical trials and the interpretation of those trials more difficult. Also, there are some important questions that have not been answered 100% one way or the other. For example, how early to start, when to stop. I think we have all pretty much agreed on, but you might still find some differences among different clinics. And then obviously how to best manage the side effects. And although for some side effects we had pretty good guidelines, for others, especially for example bone osteoporosis, for example, we're still learning a lot about how to best manage that particular side effects. And then the fact that really, if you go around the world, there are entire countries that are still not really using corticosteroids, and then a lot of different regimens of corticosteroids. So a major clinical problem that has been brought up by the NIH and by parents, patient organization, and really we can definitely use more data on some of these big questions. Here is an example. This is part of the work that was done in preparation for the 4DMD trial, which I'm gonna tell you a little bit about. And this work was done in 105 different clinic centers in Europe and in the US to really figure out, okay, which ones are the most commonly used regimen. And the top four here is important for you to see. So the first one is the daily prednisone of 0.75 milligram per kilogram per day. 61 centers use that regimen. The prednisone 0.75 milligram per kilogram, 10 days on, 10 days off, was very high at 36 centers, although we recognize that that was mostly a European time of regimen. The daily deflazacort at 0.9 milligram per kilogram per day, 32 centers, and then a kind of a far fourth one, but becoming more and more popular, I will say, in the United States and certainly in certain clinics, and especially for the very young or the very old patient, is the high dose weekend with prednisone that was published and used by Dr. Connolly. But this is just to give you an idea that this is a very heterogeneous type of landscape when it comes to use of corticosteroids. And clearly this was studied to really raise this issue. So other data that we have collected, I don't know if you're aware of the MD-StarNet, but what MD-StarNet is a research funded by the CDC, by many different sites in the United States, and it's really supported by many of the patient organization, and it's really a surveillance. So this is not just the studying patient that go to certain clinic. This is an active public health surveillance. So the health department of those states actually go into the chart of patient with Duchenne, and they abstract different medical information, and then they do research to figure out, you know, answer certain questions. And certainly there has been a number, many publications out of this research. And one was really to look at the situation with corticosteroids and are we making progress in terms of treatment. And so many of the publications, so we looked at it first in 2005, and we realized that there was really only 44% across all sites of patients that were actually on corticosteroids, so that was a little bit discouraging. And that even among different states and different clinics, really that average between 15% and 49% of patients. So, you know, this has improved over time, but at that point we were really a little bit discouraged that the implementation was not really translated in real life very well. And also the other thing that we learned from the study is the median age when corticosteroids were started was 6.9 years, which is definitely way too late. And also the most common reason for stopping corticosteroids was weight gain, behavioral side effects, and loss of ambulation. And so now with the loss of ambulation, obviously with the care guidelines statement, hopefully that is really changing finally. And then, you know, we continue to study this topic of corticosteroids in real life through surveillance, and the MD Starnet subsequent studies and publication have actually learned that there is actually a positive trend, and steroid use has increased from 54% to about 72%, and the mean age of steroid initiation has actually decreased over time, so that's positive. We still have much work to do, and we know that Hispanics and non-Hispanic Blacks males use of corticosteroids is even less in those minorities. But that overall, I think the field is going in the right direction, and the percentage of patients actually treated with corticosteroids is overall increasing, which is very positive trend. So the other thing that we have learned again from some of the MD Starnet is that when we looked at the outcome of echocardiogram and cardiomyopathy, we know the corticosteroids actually have a beneficial impact in delaying the cardiomyopathy. And there are several papers now out. This is just one example that came out of the MD Starnet effort and research. But basically that by age 14, 36% of boys treated with corticosteroid had developed cardiomyopathy, compared to 63% of inpatient not treated with corticosteroids. So basically a delay of 2.1 years in onset of cardiomyopathy. So very important thing to remember. The other thing that we are not 100% in agreement across the field and across the world is obviously, you know, the Flazacort versus prednisone. So what are the, what data do we really have to make the best informed decision about one or the other? And again, I want you to kind of think about it in terms of short term, long term, the efficacy, the side effects, and also access. So as you know, the Flazacort has been available in Europe and many other countries for decades, but in the United States has only been approved recently in February of 2017. So I just want to remind you that in the United States, prior to 2017, yes, family and patients were able to access the Flazacort, but they had to pay out of pocket. They had to order it online or in other ways from different countries, Canada or Mexico, which really, if you think about inequality in healthcare, obviously you can imagine that, while for some family this was probably very doable, for other family, depending from their social demographic or the ability to pay out of pocket, that obviously would have been a barrier to access the Flazacort. So this is just a reminder that now the Flazacort has been FDA approved, and there has been a change, which I think is important because it tells you where the field is going in terms, remember how we discussed, well, how soon is best to start corticosteroids, and I think the field is moving to earlier and earlier overall. But the label for Emflaza, so the indication has now moved from 5 years old of age and older when it was first approved, and then it got changed to 2 years of age and older. So I think that also reflects, I think it's a positive thing, and it also reflects that the field is really thinking about this particular topic in a very aggressive way, and we're really having more data that I will share with you in a moment. So I think that the FDA approval of the Deflazacort has been a very positive thing for the field. We do know that unfortunately among providers, the opinion is not yet 100% uniform in terms of preference of one or the other. I particularly say that it's extremely important to have both available to anyone who wants it or that is recommended by their provider. So I think it's an extremely positive, encouraging change. And you know, where before we had more of a inequality in access because of having to pay out of pocket and how to get the medication, in practical reality right now there might be a little bit of, sometimes in some states and with some insurance policy, there might be sometimes some barriers because some policies might use the data available to say, well, they both work very well, so we would like for this patient to try prednisone first, and then if they fail prednisone, then we'll allow and we'll cover for the Deflazacort. We hope that this eventually is going to get better and better over time, but if you sometimes, you might have experience through your particular clinic or provider that you had to wait maybe sometimes to before being able to receive the Deflazacort through your insurance. That's just how it is right now out there, depending where you are geographically. So what do we really know? How can the data help us when we have that discussion about the Deflazacort versus prednisone? Where there was a trial, actually, a side-to-side, so a comparison trial that was completed in 1995, and this is just to go to show you how it goes with rare disease. It was never published, so it was only published in 2016, and this is really the paper that really helped for the FDA approval, and it was a multi-center phase 3 double-blind placebo control of 196 boys between 5 and 15 of age. So this was finally published in Neurology after so many years from the original trials. And here I'm going to try to tell you exactly. So they looked at 3 regimens, so 2 different doses of the Deflazacort. So the light blue is the Deflazacort 0.9 milligram per kilogram. The darker blue here is the Deflazacort 1.2 milligram per kilogram per day. And this is the prednisone 0.75 milligram per kilogram per day. So all daily regimen. And here is the placebo. So they did placebo versus these 3 regimens for 12 weeks. And clearly they show unequivocal efficacy of all 3 regimens versus the placebo. So the placebo, obviously, this is muscle strength, clearly decreased in 12 weeks in the untreated group, in the placebo group, and all 3 groups, the Deflazacort and prednisone, significantly had significant improvement in muscle strength. So this is really strong. What we call class 1 evidence is the strongest possible evidence for efficacy. And the muscle strength change was significant in all 3 groups. They also did also studied the pulmonary function, standing from supine, climbing 4 stairs, and running, walking 30 feet. And all of those show improvement in all 3 regimens versus the placebo at 12 weeks. But then the study, they took all the patients that were in the placebo, they put them in one of the 3 treatment of either the Deflazacort or prednisone at the different doses, and they kept studying them up to 52 weeks. And here you can see that both doses, the pale blue and the darker blue here are the two deflazacort, had more significant improvement in strength than the darker blue, which is really the daily prednisone at 52 weeks. And then the side effects. So I think that what this paper really helped confirming in the community is the different profile in side effects. So at 52 weeks, there was clearly more significant weight gain, 18% in the prednisone treated versus 5% increase in weight in the deflazacort treated patients. Although weight gain is an issue with all corticosteroids, this is what the study showed, that it was more prominent with prednisone, but for shorter stature and cataracts, the reverse was true. That was more significant in the deflazacort treated patients than in the prednisone. And then a little more behavioral side effects with prednisone versus deflazacort. So again, these are very important things, because weight gain, you also have to think that weight gain that was worse with prednisone could also have a negative effect on ambulation. Just by being heavier, that can really have an impact. On the other hand, the short stature, which obviously in terms of quality of life can be quite significant, obviously, but from the motor function point of view, short stature might actually have a biomechanical advantage on ambulation. And this is something that the experts in the field are really looking at a little more in closer. So that might actually have an advantage, although being a side effect. So other data that kind of compare deflazacort versus prednisone, but not in a setting of a clinical trial, so not in a control way. This is data that was published, and what they did in this study, you might be aware that there was a clinical trial for ataluren, which is a medication for stop codon mutation. And so they did the post-hoc analysis. So when the trial was finished, they actually used the data from the people that were on the placebo arm. So they did not receive ataluren, but they all were on corticosteroids, 230 patients there. And they really looked, the primary endpoint was the change from baseline to week 48 in the 6 minutes walk, and they compared the one on deflazacort versus prednisone. As you can see here, the people on deflazacort only lost 39 meters on the 6 minutes walk, and the patients on prednisone, they lost 70.6 meters over that period of time of 48 weeks. Obviously, this is a cohort that was followed very carefully in a clinical trial. Nevertheless, it was not a controlled trial. So these data are important. I think they add significantly to our knowledge, but they need to be looked in that optic of some limitations. And then they also went farther, and they really looked at other motor function tests, like the four-stair climb, and the ones that you can see, also some quality of life. And basically, when this line is over to the right, these are all in favor of the deflazacort versus prednisone. So this is fully published, and I think it adds to our knowledge, where most of this motor function were in favor in patients using the deflazacort. We have another large cohort now published. The Synergy group is the largest existing prospective cohort. So these patients are followed not in a clinical trial, but prospectively with established uniform standard of care. And they studied a large group that is really across, it's an international group, natural history. And what these have shown, first of all, that again, we knew already there are about 14 different regimens of steroids, but when you really try to compare the deflazacort versus prednisone, you can see that the median age of loss of ambulation was 13.9 years of age in the deflazacort, so later versus prednisone was 11.2, and this shows you the green is the daily deflazacort, where the black is the daily prednisone. So they separate. Anything that goes to the right is a better outcome. And this is now published and also recognized in the community as adding some evidence. In that study, they also look at the physician-reported side effects, and these were the most common. Obviously, weight gain. You can compare prednisone to deflazacort. Behavioral change, quite similar. Growth delay, much more prominent in the deflazacort. And then, you know, other studies from the synergy. Again, this is an interesting study because they really looked at other motor important milestones. For example, time to stand, loss of ability to stand, climbing, and loss of ambulation. And this is really, now this is not deflazacort versus prednisone. This is really, the blue are patients that were never received corticosteroids, or they received corticosteroids for less than a month. And the red dots are patients that were on corticosteroids, either one, deflazacort or prednisone, for at least a year or greater. And I want to show you this because, again, this is overwhelming evidence that everything is pushed to the right, including, very importantly, loss of hands to mouth function, which is very important, and loss of distal hand function. They're much delayed in terms of loss for patients who are treated with corticosteroids versus the blue one that have not received. So again, this is to summarize this data that I just showed you, that findings suggest that the deflazacort therapy may confer benefits as compared with prednisone. Maybe greater muscle strength and definitely less weight gain. And from other different uncontrolled cohorts, a delayed loss of supine to stand, loss of ambulation, and hand function. So very important data. And so the other big question that I want to go over real quick is, so when should we start? You know, we know that usually boys with Duchenne are average, they're diagnosed at age 5, which is still too late. We're trying to push and improve that. But in those children that are actually diagnosed much earlier, or maybe because of family history, what is the evidence that maybe, you know, starting treated at 4, 5, or 3 is not enough, that maybe we should consider treating earlier? And the only study published that I know of at this point is the Dr. Connolly study that really did a well-designed trial of 1 year, open label, of course, of twice weekly prednisone in boys that were 4 to 2.4 years old, 4 months to 2.4 years old. And she studied the Bailey, which is really a very comprehensive scale of motor function, and really demonstrated that clearly the treated boys gain on average a half point on the scales versus the untreated boy, the natural history, lost about 1.3 points. So it's starting to emerge more evidence about maybe starting earlier. Obviously, there was weight gain, and that remained to be seen. But I think that we're building the case with study like this about, you know, if newborn screening becomes available, which I think it will in the next few years, how are we going to handle the question of when to start corticosteroids? And then I'm just going to leave you with the fact that, you know, some of these unanswered questions in regard to the deflazacort versus prednisone hopefully will be answered very, very soon by the finally completed 4 Dmd trials, which was NIH funded. It took almost a decade of preparing and funding this study. But this was a study that it was randomized and controlled and used 3 different regimens: the daily prednisone, the daily deflazacort, and the prednisone 10 days on, 10 days off, and follows a large cohort in these 3 different regimens for a long time. And the primary outcome was really, you know, motor functions, respiratory viral capacity and also the subject and parent global satisfaction. And I think it's very important also that we should, moving forward with clinical trial, pay way more attention to patient-reported outcome and also patient and family satisfaction in terms of the side effects. And these results should be published very, very soon, but they're still under embargo because the preliminary analysis was just done very recently. So in summary, I really want to emphasize that treatment with corticosteroids is really standard of care in Duchenne. The many, many benefits are more than just short-term increase of strength, but they cover long-term benefits in terms of delaying important milestones of the disease, such loss of ambulation, scoliosis surgery, heart disease, respiratory function. The side effects are very well known and also slightly different in between the two. So the fact that we now as a community have both medication available is incredibly positive, because remember, all of these data are cumulative among groups, but when you have a single child in front of you, it is good to have option, because you don't know where the single child will have more side effects one way or the other with one medication or the other. So having option is extremely helpful and important, and now we do have that. And then some of the uncertainty remain on how early to start and what regimen, but I think that the community at large is working very, very hard to try to get best answer to patients and their family and to the community at large. So I think we're going to continue to see very good progress in the field of corticosteroids in Duchenne. So this was kind of a high kind of overview. I hope that maybe for you, you learned something new. Maybe you already knew all this, but regardless of where you come from, I will be very, very glad to answer any question. And thank you for your attention.
Thank you so much, Dr. Cipollone, for that presentation. That was fantastic. As Dr. Cipollone said, right now we'll be taking questions from the audience, so please feel free to drop it in the chat section below if you have any.
And you will read them to me, right? I don't think I'm quite seeing them. So.
Yep, I'll read them.
Thank you.
All right. I don't see any coming in just yet, but I've got a question.
Sure.
Oh, wait, we do have one. If both are different in impact, why do you think they are treated similarly for clinical trials? I guess.
Say it again. I'm not sure I understand the question.
Yeah, I don't understand that question. If you did write that, can you please write back in which both you're talking about? Okay, well, I'll skip that one for now. We'll go back to that one.
Maybe though I can make a comment, because this needs to be clarified. So right now, as you know, there are very, very many clinical trials ongoing for Duchenne muscular dystrophy, ranging from gene therapy, exon skipping, many others. And so usually the inclusion criteria require patients to be on corticosteroids for at least 6 months. Usually could be 3 to 6 months, but to be on corticosteroids, because that's established as standard of care. What is not required though usually is that any corticosteroids go. So they could be on daily prednisone or daily interferoxacor or high dose weekend. So you see where that lack of uniform treatment. So right now for clinical trials, as long as you're on some corticosteroids and it's stable during the clinical trial, you will be allowed to participate. Maybe that is maybe a part of the question.
Yeah, I think you answered that perfectly. Thank you.
Okay.
All right, so the next one we have is my 7-year-old son takes 81 milligrams each Saturday and Sunday of deflazacort. Is there any study about this regimen?
So I am not aware of any published studies, but I will be glad to double check, that has studied high dose weekend of the Deflazacort. The published study was on high dose weekend of prednisone, and I believe it was 5 milligrams per kilogram each day, Saturday and Sunday. And that was the Dr. Connolly study. I am sure that probably some people out there are doing, but I don't think that has been studied in a clinical trial. I think that the Deflazacort, all the data that we discussed, are predominantly coming from daily use of the Deflazacort at the 0.9 milligram per day. Also, when we looked at those other cohorts like the Synergy and the ACT, so in real life, they did study this issue, and they learned the why prednisone, it's more common to go on alternate days or high dose weekend. Usually people who are on the Deflazacort, I think was 87% are on daily Deflazacort. So I think it's a bit unusual to be on alternate days Deflazacort. I don't know of any trial for that.
Okay. How would you recommend a parent that is looking to take their child from daily dosing to weekend dosing for steroids?
So switching, right? We know from these cohorts that there is quite a bit in real life, there is quite a bit of switching, because, you know, every patient is going to react a little bit different, and it's good that we have alternate regimen that we can consider. But if someone is considering going from a daily to, let's say, a high dose weekend, I think that you can do it pretty much straight away. So go from, you know, whatever dose you have of prednisone daily to just the 5 milligrams per day, Saturday and Sunday. At least that's how I will do it, but obviously that's something that needs to be discussed. And also, I think that should be guided by the reasoning of why the switch. Why are we doing the switch? Is it because they're progressing, they're getting weaker, so we don't see, you know, we don't think that they're doing well in terms of morale, or are they having side effects like behavioral or weight gain? So that might also guide how we're going to do it. But generally, if you go from daily to high dose weekend, I will just do it straight.
Okay. And just kind of keeping on that, what happens, you know, what should a family do if they skip a dose of the steroids for the day?
So if you skip just one dose, if you're on a daily, like every day, the Deflazacort or prednisone, I think skipping just one day is fine. Is not to be too worried about it. I think that the potential for adrenal problems is really when we're talking about 2, 3 or more days sudden stopping, like either because of a sickness or a surgery or something like that. That's when really the recommendation is to try to have available an alternative way of giving the steroids.
And then if, you know, a family does forget, would you recommend that they take it when they remember it, or to just kind of skip that dose and take the next one as normal?
It depends a little bit. If you remember by 12 or 2 p.m., maybe just go ahead and take it. Usually we don't recommend taking steroids in the afternoon or in the evening because the potential little bit of excitement side effects, so and keep you up at night. So if you remember early enough in the day and you can take it on a full stomach, go ahead and do it. But like I said, skipping one day is not going to be dangerous. So
that's great. Okay. Another question we have, from your point of view, if these drugs are approved, will the evidence from studies of disassociated steroids be convincing enough for providers to feel comfortable shifting the standard of care towards them in order to relieve some of the global side effects of corticosteroids?
Well, I think that the data is overwhelmingly there to tell us that, yes, this should be standard of care and it should be really offered to all patients. And I think that people that really treat Duchenne muscular dystrophy should feel comfortable prescribing corticosteroids, but they should also be prepared to actively manage the side effects in the best possible way. So that comes hand in hand. You can't just write a prescription, forget about. So that's why it takes a village. So I think that being connected to a multidisciplinary team is the best model, even if perhaps you can go see a multidisciplinary team maybe once a year, and then maybe a local neurologist managing more the day by day. But I think that the model is important. But I think that not prescribing corticosteroids in Duchenne, in my opinion, and based on all the evidence, it will be a big mistake. Now, of course, there might be very occasional cases where they absolutely cannot tolerate any regimen or any type, and that's obviously can always happen. But I think in the majority, you can find, you know, to prescribe and use quite safely.
What is the lowest dose of steroid a family can take?
You know, this is interesting. It has been studied, and I think that there were even studies about 0.3 milligram per kilogram of prednisone. It was still having some effect. And in fact, in real life, those studies, as I show you, when they try to compare the Flaxacort to prednisone, generally the people on prednisone, they're rarely on the 0.75 milligram per kilogram in real life. They're usually on a lower dose, and yet when you look at their outcome, you know, they're still do so much better than the ones not on steroids. So I don't know that there is a precise answer, but I think that even 0.3 milligrams per kilogram, I think is still worth it taking rather than nothing.
Okay, and just to follow up back from the other one, you know, what about the steroids of, you know, or not steroids, the other companies in the space that are doing, you know, Revirogen, catabasis alternatives to that? You know, do you feel that, you know, people, the providers will shift their care for that and prescribe some of those as well in the future over corticosteroids?
Well, I think that the future is very bright for Duchenne. I have no doubt that in the next several years we will have other FDA-approved medication, other genetic modifier for Duchenne, perhaps gene therapy. We will have probably some alternative synthetic corticosteroids. I think that's what you're referring to. Synthetic corticosteroids, perhaps with the same efficacy and hopefully less side effects. So I think that options are very good. I don't envision the short-term corticosteroids are going to go away and be replaced by some magic new drug. Unfortunately, I wish, but I think they're here to stay for longer. But I think there will be more alternative to it. Yeah, but I still think that the model of best treatment for Duchenne remains a cocktail of different corticosteroids and other medications.
Okay, absolutely. And then I know we're out of time here, so we'll take the last question and then we can go from there. What kind of side treatment can help accommodate or reduce the side effects of corticosteroids?
What kind of?
What kind of side treatment can help accommodate or reduce the side effects of corticosteroids?
Well, you know, I don't, so first of all, for the bone management and for growth, so for the endocrine side effects, so osteoporosis, delayed puberty, and delayed growth, there are sometimes medication that can be added, obviously for bones, you know, there are medication, usually they're IV infusion that can be used to counteract the osteoporosis. For delayed puberty, sometimes testosterone is used to counteract the delayed puberty, sometimes for short stature and growth. Some clinics do use growth hormone. I think that those is not a black and white uniform, but those are out there being used. Unfortunately, for the weight gain, I have to be very honest, in my experience, once you gain the weight, it's very hard to undo it. So I think that the best approach for that particular side effects is to really preemptively, before starting corticosteroids, to have a good talk with a dietitian and nutritionist, and also make it into a family affair rather than just the child, that really certain foods or beverages should really be, you know, limited in the household, those type of things. Metformin has been used sometimes to counteract the weight gain. And then obviously, you know, switching, you know, from one corticosteroid to another, or from daily to, so there are many things that can be done to manage the side effects, and we are learning a lot more as we go about how to manage those. So again, I would like to emphasize that because there are side effects, I still think that the benefits of corticosteroids is so overwhelmingly that I really encourage trying and then manage the side effects in a proactive way.
Okay, so we just actually have one more question, and I do think it's an
Sure.
important one, and then we'll end things. But do you recommend still taking corticosteroids in non-ambulatory boys?
Yes, yes. And when I was young and a little less smart, I guess, I will start my patient, and once they lose the ability to walk, I will stop the steroid, because that was in our mind. Now we know so much about, remember, the long-term advantage of corticosteroids. So fewer scoliosis surgeries, so the cardiomyopathy delay, the pulmonary function delay, the upper extremities function preservation. I think that the amount of data in terms of continuing the corticosteroids after a patient goes in a wheelchair, they're pretty overwhelming. I think that the majority of my colleague and expert, there is pretty good agreement about that. Now, again, you have to really still very aggressively manage the side effect. But yes, I don't recommend my patient to stop once they lose ambulation. I think that losing ambulation is a big milestone, but there is so much more, I mean, think about now, these boys, they live so long and they go to college and do many things, and preserving pulmonary function and upper extremity function, it's a huge quality of life. So I think there is a lot to gain by continuing, and I think that the data support that.
Thank you so much. If you guys have any other questions, feel free to email us at info@jetfoundation.org or Danielle@jetfoundation.org, and I can follow up with you and provide you with Dr. Cifaloni's contact information if you would like to follow more up with her. But with that being said, Dr. Cifaloni, thank you so much for hosting this with us. This was a fantastic webinar. Thank you to our friends at PTC Therapeutics for allowing us and presenting this on our behalf as well. We look forward to seeing you in the future and working more closely again with you this year. If you guys have any other questions, again, please feel free to reach out. Have a wonderful day, and I hope to see you at another webinar very soon. Thanks so much again.
Thank you. Thank you very much, everybody. A pleasure. Take care.
Bye.
Bye-bye.